Well, good morning. I'm Phillip Professor of Neurological Surgery at UCSF, and this is another Community Grand Rounds, of which we've had a series of these over the last year or two, and this one is focused on surgical treatment of movement disorders. We have a panel here with my close colleagues, Dr. Doris Wang, Associate Professor of Neurological Surgery here, and Tamara Stiep, Assistant Clinical Professor of Neurology, and we work together in an integrated clinic and make a lot of joint decisions. So let's go to the next one. Yeah, so here's just quickly our learning objectives for today. Understanding who's a good candidate for deep brain stimulation for Parkinson's disease and at what stage it should be done. Second, we'll talk a little bit about high-frequency focused ultrasound, the program that Dr. Wang started here, and when should it be used. And finally, do a little more research-oriented piece, learning about a new development in deep brain stimulation, the development of adaptive or self-adjusting stimulation and what its role might be. So I'll hand it over at this point to Doris to present the first case.
Sounds great. Can everybody hear me okay? All right. And please also, if you have any questions at all, type it in the Q&A box. And I think Dr. Starr will be monitoring.
I will.
Out, and we'll try to answer those questions. All right. So the first case is a 53-year-old gentleman who's actually a police officer, presented with slowness and difficulty walking about 5 years ago. And he was diagnosed with Parkinson's disease by a local neurologist at the time. Initially was started on Stiep, which is carbidopa-levodopa, at a pretty standard dosage, 3 times a day with really good response, where he's still able to work and to carry out daily activities. But then over the past year, he noticed that he has to take medication more frequently, now every 3 hours to maintain motor function. And what happens is that before he has to take the next dose of medication, he has severe symptoms, which is slowness, rigidity, difficulty walking. But then after he takes the medication, he develops dyskinesia, which is involuntary hyperkinetic movement. And as you can imagine, this is very debilitating for him. So he had to, leave the police force and has difficulty caring for his, children and family. So now he presents to our movement disorders clinic for options. And here's a video of him when he's off of medication. So Tamara, what do you see here? Can you describe this for us?
So when we look at his movements, he's doing some repetitive hand movements, and you can see that there's definite slowing. And as he goes on, you see even more and more slowing. That's what we typically consider as bradykinesia. Same for alternating hand movements. He starts a little bit with good amplitude, and then that amplitude reduces. And that's what we really look for that bradykinesia piece. And you can tell that he has pretty moderate bradykinesia. And it seems to be bilateral, both upper and lower extremities, right? So it's diffuse.
And can you describe his walking?
So he looks a little bit stooped. He has a slow gait and no arm swing whatsoever when he's walking. And he's holding his hands or his arms a little bit in that flexed position, kind of close to the body.
Okay. So if he comes to your clinic, are there any medication adjustments you would be making at this time?
So at this point, it looks like he's been on carbidopa-levodopa, which is our gold standard treatment, right? And he's having frequent dosing about every 3 hours. And like you mentioned, he's having these peak dose dyskinesias, which makes it a bit difficult for us to just increase his dose, right? So at this point, we would maybe consider a long-acting medication, adding a long-acting, or maybe even an extender for levodopa. However, all of these medications would carry the risk of worsening his dyskinesias. So he's at that point where he's a bit complicated and would likely start consideration for surgery.
All right. And this is a question I'm sure you get asked a lot, and we get certainly asked about this. When is a good time to consider surgery for Parkinson's disease?
Yeah. So generally, when we think of DBS, we generally kind of think about it in the context of disease progression. typically, if you can see the stage 1 and 2 on the graph, that's really early on in Parkinson's disease. Symptoms are generally really well controlled on medications, namely levodopa. However, as the disease progresses, we see that we enter a more a range or a stage in the disease where the therapeutic range or therapeutic benefit gets narrow and narrower. And this narrowing means that we can overshoot the levodopa dose and cause dyskinesias, or we can frequently undershoot it and cause motor fluctuations into this off time, right? When we have more symptoms of tremor, rigidity, and bradykinesia. And so that balance of on and off, and dyskinesias can be really debilitating for patients. And that's typically when we just start to really consider DBS.
Okay. So in all cases, this patient, is getting evaluation for DBS. And Phil, so what additional considerations are there for DBS surgery besides, this medication fluctuation?
Sure. So a big one is patient expectations that both our neurologists and us have to really talk to them about. We know that we can improve the cardinal motor signs of Parkinson's. We don't improve some of the debilitating non-motor signs, right? People can have sleep disturbances, anxiety, depression, autonomic dysfunction. Those things tend not to improve. So making sure patients have correct expectations is important. And then considering, of course, the risk side for any surgery. What are the possible risks of this surgery? And we tell patients that the most feared risk is hemorrhage, which would happen during or immediately after surgery if it were going to happen. People don't have much more risk of that after they leave the hospital. And then the more common risk that we deal with is infection, hardware-related problems, wounds not healing, and having an infection occur, which will, if it's going to happen, will occur in the first several months after surgery, and that may require removal of part or all of the device to treat it. And of course, patients may have risk factors that affect those things, right? We have to be very careful with anticoagulation, rigorously stop those anticoagulants if patients are on them. And some of our patients have risk factors for infection, diabetes, need for immunosuppressants, or just really thin skin and thin scalp.
Okay. And is there an age limit for who can get DBS?
From my point of view, there's not really an age limit. We have done, people, 80 or even early 80s, but many patients by that time have accumulated enough comorbidity that it makes the risks high. So it's always a risk benefit, and we don't have a specific cutoff time for surgery age.
And one other question I think you get asked a lot is, how long does effective DBS last?
So yeah, it's a bit of a complicated answer, because for the main motor signs that we do it for, rigidity, gait disorder, tremor, bradykinesia, the benefits are really last essentially permanently for those. But what happens when people get worse on DBS is they develop new advanced symptoms that don't respond to DBS or medications and never would have. So, and those are things like severe postural instability, hypophonia, cognitive disturbance. And so that's how quality of life can diminish after many years of DBS, not because it stops working for those core motor symptoms, but because of other things developing.
Okay. So Tamara, can you just summarize what DBS can and cannot help with?
Definitely. So DBS is very helpful at treating medication-resistant or medication-refractory tremors, also as well as reducing the motor fluctuations, reduction of dyskinesias. It has a major improvement in rigidity and bradykinesia. It can also improve dystonia in patients that do have dystonic features as part of their Parkinson's disease. And sometimes it's also helpful with some gait difficulties, depending on what is driving the real gait impairment. So it depends for the gait part.
See, and what are the symptoms DBS cannot help with?
So generally, we tend to think that DBS is not very helpful for speech problems, which include hypophonia and even dysarthria. Swallowing difficulties aren't really helped either, and something that we actually watch for after DBS. Postural instability, and many of the non-motor symptoms that you can think of, like constipation, drooling, fatigue, pain, memory, and cognitive symptoms as well, are not going to be improved with DBS.
Okay. And I think I just saw a question in the
Yeah,
chat.
yeah. There's a question. The question is, please estimate the incidence of Parkinsonian dementia and the effect, if any, of DBS. So Tamara, let's ask you. Would you first, how common is it to have a significant dementia in Parkinson's disease, and how does that affect your decision on recommending a patient for surgery?
Yeah, generally we think of Parkinson's disease, dementia as something that comes along much more or later on in disease, and within the disease progression. So typically it comes along in the advanced stages, and so we do see it, but I would say it's not in the majority of cases of our advanced PD patients. And typically, if we do see dementia, we definitely take it into consideration, and it's a big part of our actual pre-DBS workup, surgical workup. Patients really, we know that they can, that the cognition can be impacted with the DBS, so it's something to take into account. But not doesn't preclude us completely from pursuing DBS either.
Okay. And on that note, so what are the steps for DBS evaluation?
Speaking of. So typically when we first, decide the patient might be a good DBS candidate, the first test that we do is an on and off testing. So we really get to know the levodopa responsiveness, and that typically is a good indicator that stimulation is going to be helpful for the symptoms. Second is usually that neuropsychological evaluation, and really looking to see where they stand in terms of their cognitive reserve, or if we need to be a little bit more cautious about a possible, dementia or a cognitive impairment. And then the last is generally brain imaging, to evaluate, the brain and any structural abnormalities that, may preclude us from getting DBS.
Okay. So
can I ask a question, Tamara? What do you do? And some of the insurers like to see an off UPDRS of 30, a certain level of motor disability in Parkinson's. What do you do with a patient who's under that level? How mild would you go before recommending surgery?
So it really depends, I would say, because some of the questions or within the UPDRS can be variable, right? So someone with a tremor of grade 3 or 4, but with less rigidity and bradykinesia and no postural instability, no walking problems, might have a really low UPDRS score because it really just captures the tremor, right? And that tremor being disabling is really what's driving us to get the DBS. So I think that when in the context of the total UPDRS, we really try to look for which of those numbers are really driving the disability. So it's not just the number, but really where those scores lie.
And then how do you use the information you get from the evaluation DBS workup to determine the target?
So there's two targets that we generally think of when we're thinking about Parkinson's disease. One is the subthalamic nucleus, and the other one is the globus pallidus internus. And so first, what we tell our patients and what we know is that either target has similar benefits in regards to motor symptom control, and also we know that they also measure in terms of quality of life. Both have pretty good outcomes in both respects. So either one of those two targets are going to be helpful for patients with Parkinson's. But if we really have to also tailor these surgeries to our patients. So when we think about, let's say a patient is looking to reduce medication burden, generally STN is a better target. We can definitely have significant reduction in levodopa doses if that's a big burden for the patient. Let's say he's on 20 pills a day and he really wants to reduce that, then STN is likely going to be a better target. When we think about GPI, we tend to lean towards patients that have indicators that perhaps they might be a little bit more difficult to program, such as, for instance, patients who have dyskinesias at really low doses of levodopa. We call them our fragile dyskinetics, and GPI would be strongly considered in someone like that. Also, GPI is thought to be a little bit of a gentler target. So for patients that are already perhaps experiencing some cognitive decline, GPI might be favored compared to STN.
See. And so Phil, how do you do the surgery itself?
So we have really two main different methods for doing this surgery, and it's for adult patients. It tends to be patient choice which one they get. So the classic one that I learned originally in my fellowship is so-called awake surgery, which is a bit of a misnomer. Patients are actually sedated at the beginning and end of surgery, but they're awake, as you can see in the lower videos. They're awake for part of the surgery to do microelectrode recording. You see that in the upper right, and that's to just determine that we've aimed at the exact right target by recording the cell activity that shows we're in the right target. And we can actually test the effects of the lead intraoperatively. So this is a classic method that at least half of our patients still undergo. And a second one is a method where patients can be completely under general anesthesia, because it can be a lot to ask of some patients to have this awake part of the surgery. Some people have a lot of anxiety around it. Some people have very severe pain and are off medication state, and they do have to be off medications for the awake surgery. So, we've needed an alternative to that classic awake surgery. And some around half, a little under half of our patients have surgery under general anesthesia, where we do the surgery inside of a high field, high quality diagnostic MR, and it's not in the operating room, it's in radiology. And this is a technique now that a lot of centers around the US are doing as a kind of so-called asleep DBS surgery. And you can see on the lower right, we can see in real time as we pass instruments into the brain where they're going and get high resolution confirmation anatomically that we're in the correct spot.
Which method do you prefer?
I really like both of them. I love I got into this field because I was interested in neurophysiology, and I love neurophysiologically guided surgery. And it's as you know, Doris, it's a wonderful moment in an awake patient when they tell you, doc, you hit the spot, right? Suddenly their rigidity melts away, and the single unit recording is very compelling to use that. But on the other hand, the interventional MRI has in our group same risks and benefits. It can be more comfortable for other patients, and we enjoy that a lot too.
Absolutely. Thank you for inventing that method. So, the patient we talked about in the beginning, he ultimately underwent bilateral DBS implantation, and the target that was picked was the STN, and he chose the surgery actually awake using the stereotactic technique. And this is him actually off of all medication for 22 hours with the DBS turned on. Tamara, can you describe it?
So we can see definite improvement in the bradykinesia. His movements are pretty fluid, and you can barely see any bradykinesia at all, right? It's pretty fast without any decrement. The amplitude is nice and big, and perhaps slight decrement, but very, very minimal. Mm-hmm. And it's bilaterally.
Just walking.
So now his gait is fast. He's swinging his arms bilaterally, and even his posture, I think, is a little bit better. Yeah. So remarkable improvement.
Yes.
And this is still off medication, right, Doris? Correct. Yeah. So that's not the effect of medication. It's purely the effect of the stimulation.
Right. He's been off medication for 22 hours at that point. All right.
All right. So I'll start with case 2. All right, so we have a 76-year-old right-handed man with long-standing essential tremor since he was 30 or in his 30s. He's tried propranolol and primidone. Both have been either ineffective or he's had side effects and hasn't been able to tolerate, or hasn't had any effect in terms of tremor control from either of these medications. In terms of medical history, he also has diabetes, hypertension, and coronary artery disease. Here we have a little video to see what his tremor looks like. So when we look at the tremor, we tend to look at a few things. For him, you can see that the tremor is initiated as soon as he starts to move the hand, and that's really what we consider a kinetic tremor. And his tremor is ongoing as he's moving towards the target and when he gets to the target. And when we first started the video, we saw that he had no rest tremor at start. So as he's holding the bottle, you can see he gets closer to the mouth, the tremor kind of gets worse, the amplitude and the frequency gets a little bit worse. And that's also something that we tend to see with essential tremor typically.
All right, is that called postural tremor? When you
It's a
hold
postural, yeah, it's a postural tremor as well, yeah.
Okay.
All right. So Doris, for a patient like him, what are some of the considerations that you would think of if since I'm already thinking that this patient hasn't been able to respond to any medication, he has a medication resistant tremor, and I don't think that I'm going to get much more benefit in terms of tremor control on any kind of standard medical therapy. What are some of the considerations you would take into account for surgical intervention?
Right. So the two main surgical options we have for people with medication resistant or refractory tremor, essential tremor, is DBS or focused ultrasound or lesion-based therapy, I should say. So DBS, obviously, as we talked about, is neuromodulation. We typically target the thalamus in an area called the ventral intermediate thalamus. And it's part of the cerebellar dentatorubral motor tract that's involved with tremor generation. And we know that, DBS works fantastic for these patients. And lesion-based therapy actually, was around long before DBS came about. But, some of the more novel ways to perform lesion, instead of, putting a probe and burning the area, or using ionizing radiation and wait for the effect to take place later, is actually an immediate treatment called a focused ultrasound. So it's an incisionless technique in which, we don't need to cut into the scalp or drill a hole into the skull, but it uses high frequency ultrasound energies to cause a thermal lesion. So it's thought to be more precise because we do this under MR guidance. So for a patient like this, a lot of it is, as Phil mentioned in the previous case, about their surgical risk. So this guy has diabetes, which is, known to increase the risk for infection and coronary artery disease. So he has, microvascular changes, probably higher risk for developing intracranial hemorrhage. And then the other thing we need to consider also is, proximity for these patients to go to a neurologist who can program the device. Should their tremor get worse, should the device malfunction, or should the battery run out? And ultimately, now it's patient preference. Now that focused ultrasound is approved for treating bilateral tremors, you can get it twice, just 9 months apart. So now it's, a combination of these when we consider DBS versus focused ultrasound.
Awesome. And how about, what is it something that you would consider, or who would you think that cannot get HIFU? Like, who can't get it?
So patients will have contraindications to MRI. So basically people who are extremely claustrophobic, because we can't, give patients sedating medication. We really need them to be awake for this, continuous intraoperative or intraprocedural feedback. Otherwise, patients who have metal implants, so people who have previous DBS, people who have shunts, cranial plates actually is not a contraindication. I just did somebody who had previous brain surgery, and that was fine. And then skull density, actually, it's a kind of a candidacy main point for getting focused ultrasound. So it measures how basically homogeneous your skull is. It has to be over a certain density. The number we're looking for is above 0.4, because otherwise your skull kind of deflects or absorbs most of the energy. So then we can't reach enough temperature to actually result in a successful treatment.
Got it.
And this is just an animation of what the procedure is like. So patient's head is shaved, and we do place him in the stereotactic frame, a head holder, and they're fixed to a table so they can't move. And their head is placed in that helmet-shaped device, which is a transducer, which has 1024 ultrasound elements. And just like a magnifying glass, each beam by itself is harmless, but where they focus, we can deliver enough energy to increase the temperature of the brain. And the nice thing about this is, we can do multiple tests. They're called sonications before we commit to a permanent burn. So if we're in the wrong location, we would know right away.
Doris, I have a couple questions for you. You probably have patients coming into your office saying, "Oh, I heard there's this new non-invasive technique to treat my tremor, and that's what I want. What do you tell those patients?
I say, focused ultrasound, if anything, is more invasive for the brain because we're actually, causing a burn or lesion, which measures about 5 millimeters, sometimes even bigger in diameter. Whereas DBS, well, surgically, yes, we cut the scalp implant devices into your body. We're not actually destroying tissue. And that's DBS is actually reversible, whereas lesioning procedure, it's not reversible. So I just say it's incisionless, but in terms of invasiveness, it is actually still invasive, and more so in some aspects in DBS.
That's a great term to use for it, in incisionless. And another question is, this is a great treatment for tremor. For a while, other lesioning surgeries like pallidotomy, surgical lesion of the globus pallidus, have been effective if done correctly for rigidity and bradykinesia in Parkinson's disease. Can you do a pallidotomy with focused ultrasound?
Yes, you can. And in fact, there was a paper out, I think just last year or a couple of years ago, about the efficacy of unilateral pallidotomy to treat motor complications of Parkinson's disease, like rigidity, bradykinesia, as well as dyskinesia. And it showed benefit. I think it was about 67% of the patients responded. And of those, all had some, met the endpoint. But, it's really pallidotomy, you can only perform it unilaterally. So you can't, treat both sides of the body. And while it's FDA approved right now, insurance doesn't approve it. So it's hard to actually perform these procedures right now.
And I think just because of the shape of the globus pallidus, doing a radiofrequency pallidotomy, which is what I learned in my fellowship with 200 cases, is a demanding operation to do correctly. It's a harder shape and must be a bigger lesion than the thalamus. So, as we know, the results of the pallidotomy study so far have been, yes, and many patients have benefited, but not that much quantitatively, right, compared to a really well-done radiofrequency pallidotomy. So I think the jury's still out on how good that's going to be for the pallidotomy.
Right. And even, for focused ultrasound thalamotomy, in which we just do 2 lesions with a high energy, actually, I can kind of demonstrate here. So this is kind of how it works, at low energy sonications. We raise the temperature of the brain tissue to about, 50 degrees for physiological verification to see if we're in the right spot to suppress our tremor without causing side effects. So it's fully reversible. But when we get to higher temperatures, that's when we get to the ablative portion, and it causes an irreversible lesion. And those can be really, really high energy and can be really uncomfortable for patients. And, skull density plays a role into this. And I think, even with 2 lesions for thalamotomy, we have to really coach patients to get through it. So I would imagine with a pallidotomy, which requires more lesions, larger lesions, it would be hard for patients to tolerate. And the other thing, that makes this technique a little bit more precise and accurate, I think the traditional radiofrequency, done in the OR heating, is that during the procedure, we're getting continuous images, almost in real time, using MR thermometry. So where we can actually accurately demonstrate and predict the temperature of the brain tissue and know the shape of the region we're heating up. So I think in a lot of aspects, it would be safer to do it this way. Yeah, and then so ultimately, this patient ended up getting HIFU just because he lives really far away. He didn't have any interest in getting brain implants because he's pretty active and wants to be outside. And this is the efficacy of HIFU. I would say, we kind of tell patients at least 80 to 90% immediate tremor improvement. And while, we've been only doing this for a year and a half at our center, what's been published out in literature is, on average, there's about 70% tremor reduction at 5 years. So the effect is, equivalent to that of DBS. So tremor may reoccur due to progression, or maybe the lesion size wasn't big enough, but still we do expect people to have sustained benefit.
And I do see a raised hand from Eddie Chang in the audience, our chair. If Eddie, you want to use the microphone and in the room to ask your question?
Can you hear me now?
Yes, we can.
Yeah. Doris, thanks for talking about the HIFU. This has really been a game changer in some ways. As you guys have pointed out, really evolution and return of palatotomy. At one point you mentioned that you don't think it can be used bilaterally for Parkinson's disease. And do you think that that's just because we don't have the data, or that the morbidity from it we already know is going to be problematic?
Yeah, I think the morbidity, based on previous palatotomy literature, is too great, and Phil can probably actually speak more to what is known about bilateral palatotomy.
For a palatotomy to be effective, it has to be pretty large and take out the entire posterior third of the globus pallidus. And it encroaches on the cortical bulbar tract slightly in order to get the most benefit in the palatum itself. If you do that bilaterally, there's a big incidence of severe hypophonia and even some cognitive problems. If you do small lesions bilaterally, you can avoid those problems, but those lesions aren't that effective.
Got it. An additional question for all of you is the lack of benefit, or perhaps even the worsening of speech, is something I've never fully understood. Do you guys have specific thoughts about why that might be the case? It doesn't have to do with the targeting, or that the voice-related changes are just a different mechanism altogether.
Mara, do you have any thoughts about that? Why doesn't speech benefit, or why can it get worse with DBS?
I think that part of it, part of it is that that it's probably not a mechanism that we're very much able to capture through DBS. We generally tend to think DBS is really good at controlling symptoms in the periphery, right? So rigidity, tremors, and stiffness in the hands and the legs, but it's fairly difficult in controlling a lot of the axial symptoms generally. And so that's when we think of like the swallowing and the speech as being one of those axial symptoms that really doesn't respond so well to DBS. I think the other part of this is that sometimes we do see worsening of these symptoms, and generally I think that it happens in the context of stimulation effects. Sometimes if we're close to the capsule, we can get, motor problems that are, capsule or that are causing changes in speech or dysarthria or whatnot.
Yeah, all of our major targets for DBS and movement disorders are actually, if you're in the right spot, you're pretty close to the cortical bulbar fibers. And so being a little bit misplaced laterally, or just having to use high stim currents to cover the whole nucleus, it's pretty easy to spread out to those cortical bulbar fibers and have a stimulation-induced hypophonia or dysarthria.
But I have to say, I think in the case of essential tremor and patients with vocal tremor, DBS can actually help reduce that vocal tremor. And now there was just something published that even with unilateral thalamotomy, HIFU thalamotomy, of course, we're targeting it to treat somebody's, arm kinetic tremor, hand tremor, but, a subset of patients' vocal tremor actually also improved.
That's really cool.
Yeah. All right. So yeah, as you can see here, the patient did perform really well, basically have almost complete resolution of his tremor, and he's really happy.
Yeah, we see that there's no tremor either on the way to the finger, and when he gets to the finger, he's nice and steady.
Okay. Actually, I do have one more question for you, Doris, on case 2 before we go on. What you mentioned, patients can have discomfort when the lesioning is happening. What is the discomfort? What is it from?
Right. So that's coming from, amount of energy we're applying, for a typical lesion, like something like 15,000 joules to the head area. So discomfort comes from, pin placement, and also, their head is in a cold water bath, which conducts ultrasound energy. It can be uncomfortable, but the sonication itself can cause dizziness. So I think some people feel like they're riding a roller coaster, falling backwards. And again, those are momentary. The sonications only last typically, between 10 and 20 seconds. And then some people describe, severe headache, like burning, stabbing pain. And it takes quite a bit of effort, to actually get somebody through it. And I think it just from the dura, and the pain receptors in the head absorbing the sound the energy.
And so it sounds like you do a fair amount of pre-op teaching, though, on these patients. They know what to expect, and that'll help them get through those things.
Absolutely. And I think patients are really motivated, by the time they get to this point. They've lived with it forever. And when they can see their tremor during the testing, we're doing the testing constantly throughout the procedure. As they see their tremor get better, they're more motivated to get through another sonication if it is painful. I would say about 50% of the patient describes some discomfort, but only like 20% have, severe headache. And a lot of it is related to their skull density.
I have one question before we move on. So what's the typical after surgery, the most common side effect or side effect that patients can experience after the surgery, after the procedure?
Yeah, so common risks of surgery include, kind of encroaching on the surrounding structure. So if you're really in the target, they shouldn't get any side effects, but brain swelling can happen because, we just created a pea-sized hole in their brain. So brain swelling can cause, balance disturbances. They can feel a little bit of heaviness. We haven't had any true weakness. And it can also cause sensory changes because it encroaches on the sensory nucleus of the thalamus. So people can have numbness, tingling. Some people actually report, abnormal taste. But those usually resolve with a little bit of steroid within a few weeks. The long-lasting effect, I think that's if the lesion is larger than expected and you're actually in some structure that causes, permanent damages. But luckily, we use tractography at our center, and we haven't had anybody with, balance issues or weakness.
Okay, well, that's Doris. The focused ultrasound program has been a great new, relatively recent addition to the program, and you've already done a lot of cases. And thank you for launching that. It's really successful and great to see.
Thank you so much for all the support. And
so, go ahead.
The last one.
Okay, so I'm going to present this final case. The first two cases really were talking about standard FDA-approved therapies. This is going to illustrate a little bit of the frontier of neurotechnology and talk about some techniques that are really investigational. Okay, so I'm going to be, in this case, illustrating a new technique, adaptive stimulation or self-regulating stimulation to improve severe motor fluctuations that are not fully treated by conventional DBS. So many patients who have our normal type of stimulation where it is constantly on until it is at a constant amplitude until it is changed by the patient or clinician. Many of those patients do very well and wouldn't need anything else. But here's a case where the person actually does need something extra. So this case is a relatively young onset Parkinson's, 59 years old. This is a 12-year history of PD. He is taking quite high doses of levodopa, 2,200 milligrams of levodopa equivalents per day. He has, as you might expect, pretty severe dyskinesias in his on state and bad motor fluctuations. So he still can have some bad off-time bradykinesia and rigidity when he wears off. So, he's a pretty young onset. He's got no cognitive problems, no history of depression. So this is the kind of patient that we would, based on what Tamara, you were saying, would do subthalamic stimulation on. Do you have any concerns if we go in and do subthalamic stimulation, this severe fluctuator, about management of him post-op with standard DBS?
Yeah, so some of these severe fluctuators, especially if the dyskinesias is really prominent, can be difficult sometimes with STN because although STN is really effective at controlling and reducing medication, it can also sometimes even, induce hyperkinetic movements like dyskinesias. And so sometimes, depending on where they're at in their dose, even while on DBS, we might see increase in dyskinesias while on STEM.
Okay, so he entered an NIH-funded research study called closed-loop deep brain stimulation in Parkinson's disease. This will often be called feedback-controlled stimulation or adaptive stimulation. And he was implanted with an investigational DBS device that incorporated brain sensing and feedback-controlled stimulation. And in addition, he had, as you can see at the MRI at the bottom, in addition to the subthalamic leads, which you see on the MRI at the right, those little white dots are the CT artifacts from the CT superimposed on MRI. He also has, on an investigational basis, permanently implanted cortical sensors, which you can see on the lower left, and these span the central sulcus that's marked with an arrow. And the reason we put these in was not for stimulating the cortex, it was just for sensing electrocorticographic activity, which we thought could provide a very useful signal for feedback control to auto-adjust the stimulator and provide stimulation during times of the day when he needs it and not provide it when he doesn't need it, and thereby do even better at treating those severe motor fluctuations than standard DBS. So first, he was clinically optimized by our movement disorders neurologist for actually over a year. And he did have the expected, really good improvement in motor fluctuations. He reduced his levodopa equivalent dose a lot, from 2,200 to about 1,100. But in spite of the benefits, he continued to have episodes of bradykinesia, especially in the morning. And you could increase the amplitude to treat that, but then we couldn't do it without provoking dyskinesia for that patient. And this, in some of the more severe fluctuators, this is a problem that you can have on conventional DBS, is that they will still have some of these residual fluctuations. So he was turned over from the clinical neurologist to our research team to implement this adaptive or self-regulating deep brain stimulation. And this slide kind of illustrates what is the idea of that. Again, this is investigational. So you have in this drawing at the left, you have a hypothetical patient who might be doing something in the kitchen and has an episode of bradykinesia. Well, these cortical sensors or the deep subthalamic sensors can sense a neural change in a neural signal that reflects that change in their clinical symptoms. So this biomarker, it happens to be gamma oscillations recorded from the cortex, but there's other things that can be used. So you can see that over the course of a few hours, if you look at the upper right, about 8 hours here, there's times when this neural signal is high, 3 episodes of that, and 2 episodes where it's low. And that really reflects his need for stimulation. So the current delivered is shown in the lower right. Every time this neural signature of his motor condition changes, drops above or below this threshold, you have a change in the current. So sometimes of the day, he's getting more like 2 milliamps, and other times he's getting 4 milliamps based upon what he needs. And so this patient we've been able to follow, we've done a randomized study of this adaptive stim based on feedback control from neural signals, a blinded randomized study of a few patients with adaptive versus continuous DBS. Some results from that blinded trial are shown here. One of the outcome measures is the duration or percent of awake hours, which they still have persistent episodes of bradykinesia. So on his standard, after a year optimization of standard DBS, he did pretty well, but he still had 20% of the day when he had episodes of bradykinesia. Then with adaptive DBS, we could reduce that, cut that in half. And you might think, well, maybe you reduced his bradykinesia, but you exacerbated the opposite problem, dyskinesia. But if you look on the right, the ratings of dyskinesia, which he only had about 6% or so of the waking day, did not get worse. And in fact, in his most recent time point, around 8 months, that is dropping. So we could benefit the residual bradykinesia without exacerbating other motor signs. So
I actually have a question. So I noticed for this patient, you use a cortical electrode, signal as a control signal for this kind of bradykinesia or signal. But can you use the DBS electrode itself as a
yes? Yeah, you can. And, there are other groups interested in adaptive stimulation. There is a multi-center trial going on now called the ADAPT trial. That trial, in which we're participating also, is sponsored by Medtronic, who makes these devices. And there they don't have cortical sensors. They're using the standard implanted DBS lead, but you can sense brain activity from contacts around the stimulating lead because you have extra contacts in there that are not being used for stimulation all the time, and those are used for sensing. And you can use the subthalamic low frequency activity around 20 hertz or so as a marker for bradykinesia. And so that's another strategy. we put in the cortical sensors to give us extra choices and also to answer the question, try to answer the question, can you really use just the depth leads alone? Do you get enough signal from that? Or is it useful to have sensors in other parts of the brain where you can collect these signals? And in our study, we now have about 8 hemispheres in 5 patients running on long-term on adaptive stim. And the majority, but not all of them, are using the cortical signal, but in some, the subthalamic signal was actually better.
Thank you. And what patients would benefit from adaptive DBS in the long term, and what patients can just stick with, conventional DBS?
Yeah, this is really evolving, and we've illustrated here one form of adaptive stim, one that adapts to their medication cycle, right, and basically seamlessly integrates stimulation therapy with medication therapy. Probably the kind of patient who's going to benefit from that are these severe motor fluctuators who are on high levodopa doses, and even after dropping a lot from subthalamic surgery, and it may again be a goal to drop from those high med doses, so they need the subthalamic implant. But those patients who still are on residual levodopa to treat sometimes non-motor problems or residual motor problems, they will benefit from adaptive stim. This is a big topic, and there's other forms of feedback-controlled stimulation that may have other indications. Many groups, including ours, are interested in improving sleep with adaptive stim, and that could be a wider group of patients that could use this. And I do see a Q&A question. How does battery life differ in adaptive stim versus the standard continuous stim? That's an excellent question. It does take energy to do the sensing. This study, our study was done with a rechargeable pulse generator, and so we're not as concerned about draining the battery, but the sensing subtracts about 20% of battery life if you had a primary cell non-rechargeable generator. So it is a consideration. One thought, and this is a thought in the Medtronic ADAPT trial, is perhaps if you can use this adaptive function to only deliver stimulation when needed, you might reduce the overall electrical energy delivered in stimulation, and that would more than make up for the energy cost of sensing. That may or may not be borne out. We've actually found in this study with a rechargeable generator that the use of adaptive stimulation has allowed patients to get more stimulation therapy because it can now be delivered just when they need it. And so we're not getting a benefit for electrical energy, we're getting the benefit in the patient doing better. And they may have to recharge a little more often, but they don't have to have surgical replacements more often of the pulse generator. Doris, do you want to mention some of the other possible things you might be exploring in the focused ultrasound program, or what are some of the research uses of focused ultrasound that might be of use in functional neurosurgery, neuro-oncology?
Absolutely. So, besides a high frequency ultrasound that creates a lesion, we also have, a low frequency ultrasound. So it's lower energy. Basically, you can capture, larger brain areas. It's not used for lesioning, but it's, being used for a lot of oncological purposes. I think UCSF is participating in some clinical trials for the diffuse intrapontine glioma for kids, which it can, low frequency ultrasound can open up the blood-brain barrier. So we think it can, more efficiently deliver chemo agents to the brain. And then there are some what we're actually trying to apply for is this really low stimulation to probe what are the optimal targets for a permanent lesion, or even for DBS. So this has a lot of implications for neuropsychiatric diseases. As you and Dr. Chang knows, right now sometimes we have to place multiple electrodes throughout the brain to find out the optimal target to treat, say depression, anxiety, some of these psychiatric diseases. So the idea is now we can, temporarily disrupt the circuit in various areas while they're fully reversible, to see maybe now we can implant electrodes in those areas in a more targeted approach. So yeah, those are areas we're trying.
So that's great. Yeah, so you have a patient in the MRI and the focused ultrasound unit, and you can do non-destructive temporary lesions, a lot of different places in the brain. and see in real time what the effects of those are.
Right.
What about, I know there's issues with doing those lesions, the permanent lesions are easier as you get toward the midline of the brain than the periphery. Is that true in this newer technology of the lower energy temporary lesion? Can you do this to the cortex, or is that still technically a problem?
Yeah, because we don't need to focus, and the energy delivered is much less. So the area of the brain that you can penetrate with a low frequency is much wider, and you could get to some cortical areas.
Okay. Any other questions, comments before we wrap up? Let's see. It looks like we do have another in the Q&A. For patients who may benefit from adaptive stimulation as their Parkinson's progresses, what is the surgical workflow to transition from conventional to adaptive stimulation? So this is, I like the way you're thinking about this as a clinical therapy we're going to offer, and one of my dreams is to have an adaptive stim clinic, basically, to do just what you're asking about. Right now, patients in adaptive stimulation are all in research studies, and they're carefully monitored. And what we're doing so far with our cohort is we do standard clinical programming. A number of them have done so well with the standard clinical DBS, they haven't entered the adaptive stim arm yet. But as we follow that pretty small cohort, we've implanted these devices now for adaptive stim in a total of 20 patients. Yes, it is true that I think some of the Parkinson's patients who were doing too well on standard stim to enter the adaptive arm will transition. And I don't think there needs to be a surgical workflow for those patients. Now, perhaps part of what you're asking is, what about a patient who has standard DBS? Can they transition to adaptive? And this is evolving. The devices for DBS are more and more being enabled for sensing and adaptive stim. So I think you will see that coming up in the future. And then I guess probably our final question, because we're almost at 9, any emerging techniques to broaden high-frequency ultrasound to patients with the low skull density ratio? Doris.
I think that, technically challenging, just because, we need to get high enough energy to create a permanent lesion, as you saw in the temperature, dosage curve. I mean, so in some populations, in Japan, for instance, a lot of their patients' skull density is like around 0.3, and they have been able to do it. I suppose if you have, absolute confidence in your imaging technique and tractography, you could potentially give patients, general anesthesia, for instance, or some sedation, so they it's tolerated better, or just, coach them through it. But I think right now the technology is kind of challenging. But I suppose, I don't know what you can do to change their skull density to make them qualify for the procedure.
What percent of patients who see you in your clinic do you have to say no to focused ultrasound for, say, essential tremor because of these skull density considerations?
Yeah, probably about 5%. I think we have screened, we treated about 50 patients so far and probably screened 60, 70. And I can only remember 3 patients or so who had low skull density, which won't qualify them for this procedure. But they, I think, eventually got a DBS, actually. So there's a great other
there's always choices, right? We like to give our patients lots of choices. So we're just about at the end of the hour. So let me thank our panelists, Tamara, Stiep, and Doris Wang, for participating in this panel. It's been a great discussion. Thank you, guys.
Thank you, Phil.
Thank you.